So the next topic is about inflammation. Let's have inflammation is reaction of tissue elements to injury. So there are two phases. Acute phase, the causes of acute phase are different, and the chronic phase. In the initial and often transient injury to the chronic inflammation, the subsequent and often prolonged tissue reaction. Acute inflammation, the phases are initially vascular, change in the vessel caliber. The first is change in vessel caliber. Inflammatory cells exit at the site, Starling forces get disturbed, and permeability is increased, and there is formation of lot of exudate. Exudate cellular phase, adhesions. Then the exudate is cellular phase, adhesions of the neutrophil. The causes are most time outcome is resolution, suppuration, organization, chronic inflammation. Microbial infections may be the cause, hypersensitivity reaction, chemical, corrosive acids, alkalis, toxins, physical agents. These may cause acute inflammation. This is the diagram showing arterial, and this is the venule, extracellular matrix, normal, this like this, and when it causes, there is expansion of capillary inflammation, acute inflammation, there is expansion of capillaries, and the cells migrate inside. This is called as acute phase. Microscopic signs and symptoms of inflammation. So outcome may be if the injury is minimal, that can resolve. If there is abscess, empyema, acquisition of large neutrophils, suppuration, and removed this the delayed removal of exudate, tissue fibrosis, chronic inflammation differs into converted. Macroscopic and microscopic signs. Macroscopic, you see redness called rubor, heat, calor, swelling, there is edema, pain because of stretching and distension, loss of function. So there are three stages. One is flush, flare, and wheal. Dull red line due to capillary dilation. Initial phase is because of capillary dilatation. There is a white flare, irregular zone, arterial dilatation. So first is capillary dilatation. Initially, that causes flush because of capillary, and flare means irregular zone when there's arterial dilatation. Wheal when is edema. So this table differentiates between exudate and transudate. Exudate is high protein content, transudate is fluid is more, collotic osmotic. Here is because of increased permeability, lot of protein is lost into that fluid. 1 to 6 grams. Albumin, globin is common. Space gravity is again more. It gets clotted because protein is there. Cells have plenty, morphocytes and lymphocyte inflammation and malignancy. Transudate is because of increase in hydrostatic pressure. Colloid osmotic pressure is actually decrease. There is less protein, and whatever protein is the albumin, it doesn't clots. This is the inflammatory cells. Now, mediators of inflammation. There are now how you see a neutrophil amyloid movement to the venules. See diapentesis, escape from the vessel capillaries passively through hydrostatic pressure, neutrophil chemocyte, interleukin 8. So here you can see hydrostatic pressure is increased, colloid osmotic pressure is decreased. Normally transudate and exudate. In transudate, a lot of proteins are leaking from the vessels. Exudate proteins are not leaking, only fluids are coming inside. Now see, these are the chemical mediators of inflammation. These are histamine, lysosomal compounds, prostaglandins, leukotrienes, cytokines, nitric oxide. This histamine, this causes vascular permeability. Prostaglandins cause platelet aggregation. leukotrienes, and histothalamic reaction. What are the cells which affect these? There are endotoxic shock, nitric oxide causes acute versus chronic. In acute, there is vascular changes, increased permeability. Chronic, there is angiogenesis. In acute, there is neutrophil, and here the cells are, in chronic, cells are macrophages, plasma cells, lymphocytes. Acute may resolve as suppuration, abscess, chronic inflammation, fibrosis, complete resolution. This chronic heals by fibrosis. Cells which are involved in acute inflammation are BEM, basophils, eosinophil, macrophage, neutrophils. BEMAN. And here the cells are lymphocyte, monocyte, plasma cells, LMP. Granulomatous inflammation. Macrophages are mainly involved in this epithelial type arrangement. Peripheral large giant cells, mediators. Activated macrophages release growth factor like interferon fibroblast. Histological classification of granuloma: non-caseating, caseating, suppurative, and diffuse. Non-caseating example is heart tuberculosis and leprosy, tuberculous type of leprosy. Foreign body granuloma, sarcoidosis, schistosomiasis in this non-caseating. Caseating is soft tuberculosis. Suppurative lymphogranuloma venerum, cat scratch disease. Diffuse is lepromatous leprosy. What are the giant cells? Composed of macrophages. Types are normal, abnormal, and specific. Normal is osteoclast, skeletal muscle giant cell, megakaryocytes, in situ trophoblast. Abnormal macrophages are macrophages related to Langen. Types of giant cells: tuberculosis, sarcoidosis, Crohn's disease, viruses, herpes simplex virus, tumors, Reed's in Hodgkin's lymphoma. These are giant cells. Then megaloblasts in vitamin B12 deficiency. Specific foreign body language. Complement system. Anaphylactocin 3A, 4, C3A. These are activated C4A and C5A. Opsonins are C3B and C3BI. Membrane attack complexes C5B and 9. Plasma factors complement chemotaxis, kinase, bradykinin, increased permeability, coagulation, fibrin. What are the pathways? These are alternate pathway, classic pathway, lectin pathway. Microbes, antibodies, manage bonding. They cause C3b deposited on the microbes. To activate C3b, C3A activated cause inflammation, C3b causes phagocytosis, membrane attack complex causes lysis. Types of acute inflammation. You can see serous, peritonitis, catarrhal, mucus, cough and cold, fibrinous pericarditis, hemorrhagic pancreatitis, suppurity, there is abscess formation, membranous, there is diphtheria, formation of the membranes, pseudomembranous colitis, necrotizing fasciitis, and all this. Now you can see inflammatory mediators. These are called as interleukins. IL-1, 3, 4, 5, 6, and 10. IL-1, 6, IL-1, 2, 6. These are inflammatory, and IL-10 is anti-inflammatory. IL-1 activates beta and C androgens pyrogens. T cells secrete stimulate proliferation of hemopoietic IL-3 progenitor cells. IL-4 IgE synthesis helper T cells. IL-5 IgE activate eosinophils. IL-6 myokines muscles more inflammatory. So pro-inflammatory cytokines are IL-236 tumor necrosis factor. Cyclosporin tacrolimus inhibits IL-1, rapamycin inhibits IL-2. So how is the sequelae, resolution, suppuration, organization, progress to chronic inflammation? Systemic effects of inflammation are pyrexia, weight loss, constitutional symptoms, hematological, reactive lymphadenopathy. Chronic inflammation, it is long time, different cellular infiltrators, lymphocytes, plasma cells, macrophages. These are the main cells. Lymphoma, macrophages. Causes are tuberculosis, acute and all. Now let's go for plants affected inflammation. These are the pathways of inflammation. Effects of acute inflammation. Kinins. Factor 12 is converted into factor 12A, clotting cascade, as well as fibrinolysis. C3 is active to C3A, C5 is activated to C5A, complement cascades. Sequelae again, suppuration. Here these are the different acute inflammation. Resolution may occur, fibrosis may occur. This can lead to chronic inflammation. Chronic inflammation, the causes are most of the time the cells involved, lymphocyte, macrophages, and plasma cells, usually primary but may follow acute granulomatous inflammation, primary chronic, acute chronic, recurrent episodes of inflammation. Primary chronic phagocytic tuberculosis, viral infection, asbestosis, Hashimoto's thyroiditis. Specific unknown chronic inflammatory bowel ulcerative disease. Progress from microscopic chronic inflammation is ulceration, stasis, peptic ulcers. Case eating granulomatous inflammation, pulmonary tuberculosis. Histological Langan types of foreign bodies. Horseshoe arrangement from where particular matter is indivisible macrophages. Silica tuberculosis, horseshoe arrangement of the peripheral nuclei at one of the pole. Large cells with the nuclei. Specific microbacterium tuberculosis. This was regarding inflammation. Now let's go for the GI pathology. Syndromes which are gene implicated. Now here the syndromes which are gene implicated, where the specific genes which is causing specific syndromes in the GI tract. The syndrome, this one is first is column is syndrome, and the features and the which are genes. Familial adenosis, FAB. Polyposis, it is FAP. More than 100 adenomatous polyps in the colon, rectum, fundus. Genes responsible is APC gene. Gardner syndrome, desmoid tumors are associated with that. Osteomas are seen, mandibular osteomas, bony tumors on the skull. APC is the gene, Gardner syndrome. Trucott syndromes, polyposis, colon, CNS tumors, APC gene. Again, APC gene is there involved in the familial polyposis, Gardner and Trucott. MLH1 and PM2. HNPCC. Questions are asked most about this. HNPCC. This is colorectal carcinoma without extensive polyposis. Endometrial malignancy, carcinoma of the kidney and CNS. MSH1, MLH2, VMS2, GTB, HNPCC. Now the symptoms, these are the symptoms related with the GI malignancies. Esophagus dysphagia is caused from the extrinsic factors like mediastinal mass, cervical spondylosis. If there is problem in the wall of esophagus, eclasia cardia, diffuse esophageal spasm, hypertension lower sphincter, factors inside the wall. This is the wall physiology, disturbance in the physiology. They convert into eclasia, spasm and this. And these are some masses, tumors, strictures in the wall. That is inside. Stricture is cerebral short scaring. Neurological, CVA, Parkinson's, multiple sclerosis, brainstem. Investigation, upper GI endoscopy, motility, fluoroscopic swallowing studies, ampulities and manometry. Malignancy of the stomach, common in Japan, more common males, more in age, familial with HNPCC. Smoking, preserved foods. Pathology, intestinal metaplasia, atrophic gastritis, dysplasia, carcinoma. Type 1 associated with Barrett's esophagus. Type 2 cardia is involved. Metaplasia esophagus, subcardial type that require close gastric intestinal metaplasia, columnar type atrophy gastritis, low to moderate grade dysplasia. Staging CT, chest, abdominal laparoscopy, occult primary, PET scan is done. Treatment is proximal site, subtotal gastric 5 to 10 centimeter from esophagogastric junction, subtotal if less than 5 centimeter from esophageal junction. The distance, if it is more than 5 centimeter, subtotal can be done. If it is closer to esophageal junction, then need total gastrectomy. Type 2 junctional extending to the esophagus gastrectomy. ECG, EGC confined to mucosa. Early gastric cancers confined to mucosa, endoscopy submucosal resection is done. D2 lymphadenectomy done. CT preoperative postoperative prognosis by early gastric cancer is 90% and above, stage 1, 2, 3, 87, 65 and 18. Total gastric lymphadenectomy, roux and Y anastomosis under GA, rooftop incision is done. So again, CA esophagus, there is adenocarcinoma, Barrett's risk for adenocarcinoma linked to smoking and alcohol. Surveillance of Barrett's upper GI endoscopy, staging is done. Endoscopic ultrasound, staging laparoscopy, PET scanning if negative laparotomy. Treatment, hyperlevis esophageal gastrectomy. Now this is about malignancy, stomach, benign lesions. Staging laparoscopy for treatment, operable disease managed by surgical staging. The most standard procedure is Ivor-Lewis type of, and this procedure involves mobilization of the stomach, division of the esophagus, highest abdomen is closed, and right-sided thoracotomy performed. Stomach is brought into the chest and esophagus mobilized. Intrathoracic esophageal anastomosis constructed. Alternative surgical strategies, transhiatal resection for distal. If left thoraco-abdominal resection is done, total esophagectomy, McNeon. Other is the total. The biggest surgical challenge is anastomosis. Leak is the complication. Intrathoracic anastomosis result in medial stenitis. Has intrinsically lower systemic insult in anastomotic leak. So lesions of the liver. Now we can go for the benign lesions of the liver. Benign is echinococcal infection, fibrotic cyst, no epithelial lining, unilocular, more than 20 cm, wall thickened, malaise, secondary bacterial infection, lefty, abnormal, esophagia. Polycystic liver disease along with the polycystic autosomal dominant symptoms due to stretch of the capsule. Cyst adenoma, rare, malignant, potential, solitary, multilocular, USC, large lesion filled with the fluid, septa, surgical resection. Carcinoid tumors, these just carcinoid syndrome. Carcinoid syndrome, it is basically because of increasing serotonin level. Neuroendocrine cells of intestine, distal appendix can occur in bronchi. The common sites are intestine, distal ileum, appendix and bronchi. Hormone symptoms when disease spreads outside this. What are the symptoms? There is flushing of the face, palpitations, pulmonary wall stenosis and regurgitation. Pulmonary wall stenosis, tricuspid wall regurgitation leading to dyspnea, asthma, diarrhea. 5-hydroxyindole amino acid in 24 hours. Somatostatin receptor scintigraphy. Blood test is chromaffin A. These are the questions. 5-indole amino acids. And treatment is octatroid. What are the indications for splenectomy, trauma, hypersplenisphenocytosis? One is trauma, another is increased size of spleen, spherocytosis, malignancy, lymphoma. Splenectomy is hydrated. Technique, general incision, short gastric division is done. To deliver the spleen, splenorenal ligament has to be removed. pancreatic fistula, thrombocytopenia, bacterial infection, encapsulate. You need post-splenectomy, increase platelet, fast blood film changes, oval jolly bodies. After spleen is removed, other changes are targets with papillary bodies, antibiotic prophylaxis, and vaccine is given. Is the technique of splenectomy, Balfour's, this is a self-retained tract tissue, short gastric vessel, like a back with a large amount of blood is back all for remove back viable, highlight injury, clamp the splenic artery and clamp to be careful to wash the abdomen. Some surgeons implant portion of the spleen into the omentum. Post-operative patients require prophylactic penicillin, pneumococcal vaccine. A different position. The spleen is sometimes large. Hemorrhage complication, blood film changes over oval jolly bodies. Other film changes include papillary bodies. Syndrome, genetic defect, and these are the some of the symptoms related with the genetic defect. We have seen it: colonic familial adenoid polyposis, APC gene, features colonic adenomas, risk genetic testing, flexible sigmoidoscopy, 15 years. If no polyp, then colonoscopy. Associated disorder is fundal polyps, uterine polyps. The syndrome is MYH associated polyposis, Beliatic mutation gene, colonic polyp resection, duodenal polyposis. Peutz-Jeghers syndrome, STK11. This is again one of the commonly asked question. Peutz-Jeghers syndrome. Chromosome 19 is involved in this. There is hematomas, interception, GI feature cancers, breast cancer, cervix, ovary, pancreas, testes, annual examination, pan-intestinal endoscopy, pigmentation pattern. Cowden's disease, P10, chromosome 10q, microcephaly, international hematoma, multiple targeted screening, breast cancer, HNPC or Lynch syndrome, HNPCC, Lynch syndrome, germline mutation of DNA mismatch, colorectal carcinoma, endometrial carcinoma, colonoscopy, Lee-Fromany autosomal P53 gene, Lee-Fromany P53, BRCA1, BRCA2, 17 and 13, Lynch syndrome, autosomal colon and endocancer, younger age. There is an Amsterdam criteria, 3 or more family members. This question is asked more family members. And the question regarding family members, 3 or more family members confirmed diagnosis of colorectal cancer, one of whom first degree relative of the parent, child, sibling, 1 or more CO colon diagnosed less than. Less age, first degree relative, 3 or more family members. Gardner syndrome is autosomal family member, extracolonic skull osteomas. Again, the question is asked on this. Osteoma, thyroid, epidermolysis, mutation gene is chromosome number 5. Marfan syndrome, the question is asked again on this. 5 feature tall, high arch palate, pace, dilatation of the lung, eyes, upward blue sclera ductal, fibrillin. In this fibrillin, the question regarding this is asked. Pseudomyxoma peritonei, this is sugar Baker procedure, that is mucinous tumors. Acute intermittent porphyria, autosomal dominant, serum aminolevulinic acid, porphyrovilinogen, abdominal and neurological symptom, vomitings and depression, urine deep red, ulcerative colitis, CO colon, chronic inflammation factor, increased disease duration more than 10 years, pancreatitis, and remitting disease. Esophageal cancer, white spots, The oropharynx, broad spring, immune sufferings, liver tumors, primary cholangiocarcinoma, hepatocellular carcinoma, cholangiocarcinoma, hepatoblastoma, sarcoma, lymphoma. CT MRI increase alpha fetoprotein. Biopsy has to be avoided. Staging. 75 chronic inflammation, cirrhosis, hepatitis B infection causes hepatocellular carcinoma. Cholangiocarcinoma, bile ducts. Its cholangiocarcinoma is because of bile ducts, primary sclerosing cholangitis, risk factor, typhoid, CA19 and 125. GST. Pacemaker cells of Kajal in the stomach, 20% small intestine, sporadic, CD117, transmembrane tyrosine kinase, surgeries, tumor, one resection, immunotherapy. Peutz-Jeghers syndrome, autosomal dominant response gene is serine thiorenin, LKB, and hematomas, polyps, intersusception, pigmented freckles in lips and face, gastritis, autoimmune circulating antibody parietal cells, parietal cell loss of intrinsic factor and B12 deficiency. Type A and type B is, this is A, this one is B, enteral gastritis, peptic ulcer, reflux gastritis, bile reflux, erosive gastritis because of some stress sensation, fold. Lower GI polyps, juvenile polyps. Questions are asked on this. Juvenile polyp, hamartomas, and it is excision. It is in rectum. Hyperplastic rectosigmoid, Peutz-Jeghers, mucocutaneous family, adenomatous polyps, risk of malignancy, villus, tubulus, inflammatory. Erythropoietic fibrosis, renal failure, genetic disease of colon. This is Amsterdam criteria. This is splenectomy. 3 or more family members, Amsterdam criteria. 3 or more family members confined diagnosis of one of whom is first degree. 3 or more family members with confirmed diagnosis of colorectal cancer. First degree relative of the other two. 2 successively affected generations. One of the more cancer diagnosed 50 years family and post-clinic blood changes, whole jolly body on the same seat of example, ulcerative colitis, liver tumors, hepatocellular carcinoma, gastrointestinal tumors, Peutz-Jeghers and GI polyps, gallbladder. Inflammatory pseudopolyps, gallbladder, fibromuscular sac with 50 mm relations, anterior, posterior, transverse colon, medial quadrate lobe, arterial supply, cystic artery, venous drainage, common bile duct confluence, relations to the origin. Medially is the hepatic artery, posteriorly is portal vein. Common bile duct, posteriorly there is portal vein, medially there is hepatic artery, and duodenum there is anteriorly. This question is asked. Hepatobiliary triangle, medially common hepatic duct, inferiorly medially common hepatic duct, inferiorly cystic duct, superiorly inferior liver, content is cystic artery. Cowden syndrome. This we have seen here. Multiple hamartomas syndromes, real autosomal characterized by mucocutaneous lesions, trichomonas, oral papillomas, most diagnosed in third decade. breast carcinoma, thyroid disease, endoscopic screening is done. Oncogenes are genes potential tumor suppressing genes there. So this was about GI pathology. Lower GI polyps we have covered. Now let's see about the bone and skin pathology. So this is about bone and skin diseases. This is bone disease. A disease features treatment of Paget's disease of the bone. First is about the Paget's disease of the bone. Bone resorption, spine, skull, pelvis, femur, increased serum alkaline phosphatase. Bisphosphonates are increased. X-ray abnormal thickening of sclerotic bone. This is the X-ray finding. Thickening of sclerotic bone. It can lead to sarcoma. Treatment is bisphosphonates. Second is osteoporosis, excess bone reabsorption, demineralization, old age, risk of pathological fracture. Alkaline phosphatase normal, calcium is normal. In this bisphosphonates alkaline phosphatase increase in bone disease, Paget disease. In this alkaline phosphatase normal, calcium bisphosphonate vitamin D is the treatment. There is bone destruction. In secondary bone tumor, there is bone destruction, tumor infiltration, mural scoring of the bone destruction, increased serum alkaline phosphatase, serum calcium, prophylactic fixation, fracture healing. Bone fractures heal by clot, organization, periods. So let's see about bone pathology. Paget's disease we have seen, osteoporosis, bisphosphonates. Then osteoporosis, disease treatment, bone destruction, mural scoring to detect risk of fractures, fracture healing. How is there is the initial hematoma, then there is inflammation, callus formation, granular tissue and remolding. Factors that affect fracture healing, again the factors age, malnutrition, bone disorders, osteoporosis, systemic disorders, Marfan syndrome cause abnormal musculating healing, steroid non-inflammatory drugs. Types of bones, cancellous bone, spongy bone fractures are more stable, involve greater surface area and better blood supply. Degree of trauma, which type of bone and which the healing. More extensive injury, degree of trauma, vascular injury, femoral head, degree of embolization, separation of bone ends. These are the factors that can affect the healing of the bones. Tubercular sclerosis is a genetic condition of autosomal inheritance like neurofibromatosis. So tuberous sclerosis, it has got it is autosomal dominant and neurocutaneous features. Neuronic is developmental delay. Cutaneous in tuberous sclerosis, ash leaf, fluorescence, shagreen spots, lumbar, spine, skin, adenoma, sebaceous nose, capillute on the nails. Neurological symptoms, epilepsy, other retinal hemorrhages, rhabdomyolysis of the heart, gliomas on brain and polycystic kidney. Aggressive fibromatosis, desmoid tumor, sarcomas are again mesenchyme. Types, soft tissue, bone, soft tissue, lipo, rhabdo, mesenchymal tumor, synovial, osteosarcoma, Ewing sarcoma, chondrosarcoma. Sarcomas are size, larger in size, rapidly growing. Assessment MRI. Ewing's is common in males. Femoral diaphysis, histology is small round tumors. So sarcomas with lymph node metastasis. Now race, which are the sarcomas that cause lymph node metastasis? Race for MS or SCARID. Rhabdomyosarcoma, angiosarcoma, clear cell sarcoma, epithelial, malignant fibers in synovial cell. Osteosarcoma, liposarcoma, retroperitoneal, Most of the retroperitoneal tumors are liposarcoma, malignant fibrous histiocytoma, undifferentiated, 4 types, toriform, myxoid, giant cell, inflammatory. So this was about the tumors, sarcomas, Ewing sarcoma, osteosarcoma, and Ewing sarcoma. All races, Cossicans, cell types, spindle cell, undifferentiated Ewing carcinoma. X-ray finding here is in sunburst appearance is osteosarcoma. Osteosarcoma is, you can see in osteosarcoma there is sunburst appearance. This is the question asked. Osteosarcoma use sunburst, the clear, and while in Ewing sarcoma there is onion skin. Periosteal lifting is there, onion skin. Liposarcoma, deep retroperitoneal old age, may be differentiated, slow growing, undergo differentiation. Many tumors will have pseudocapsule. This is malignant fibrous described undifferentiated cell origin. There are again 4 types. Paget's disease, disorder of the osteoclast. Paget's disease of bone increase, uncontrolled bone turnover, and characterized by predisposing factors. Paget's disease is common in UK, but symptoms 120, increasing age, male, northern latitude, bone pain. Classical untreated features: bowing of the tibia and bossing of the skull, raised alkaline phosphatase. These are the features of Paget's disease. Initially, I have seen bone and soft tissue. The first of the Paget's. Clinical bone pain, classical bowing of the bossing of the skull. Skull bossing, bowing of tibia. Bisphosphonate calcitonin, oral calcitonin is less commonly used now. Complication: deafness, bone sarcoma. Keratosis common, fair skin people, exposure. Groups at high risk. High risk groups are renal immune compromission. These are the 0 to prognosis well. So these are about the tumors of the skin. Second most common skin malignancy derived from epidermal keratosis, common in fair skin individuals, sun exposed, may occur in perianal genital, especially in association with the human papilloma virus. 1618. High risk groups: renal transplant, immune compromise, chronic wounds, marginal ulcer, 0 to pigmentosa. Prognosis is good prognosis, well differentiated tumors, less than 20 mm diameter, less than 2 mm deep. If it is more than 4 mm deep or more than 22 centimeters, poor prognosis. Treatment: poorly differentiated tumors, more than immunosuppression for whatever reason, surgical excision with 4 mm margin if lesion is less than 20. If more than 20, then margin should be 6 mm. Squamous cell skin typically arise in sun exposure. Merkel cell tumor skin rare but aggressive, develop in the epidermal. Merkel cell periorbital ear, commonest site 5 Heliocyte collection of hematogenous place, secondary Crohn's disease, UTI, femoral artery catheter. Clinical feature: fever, investigation. CT is the gold standard. Percutaneous drainage surgery is indicated. Failure of the percutaneous drainage. Review CT scan. G. Transverse laterally placed incisions. Split and drain is kept. So this was about bone pathology. Now let's go for general pathology. This has started with this again. General pathology. One hippolymph disease is autosomal dominant neoplasia, WA gene, chromosome 3. Features are cerebral hemangioma, retinal hemorrhages, renal cyst, pheochromocytoma, extrarenal cyst, endolymphatic tumors. Tumor sclerosis are seen just now, desmoid tumors, tuberous sclerosis, sarcomas, features, having sarcoma, osteosarcoma, blood transfusion reactions. So let's go for blood transfusion reactions. Acute transfusion present as adverse signs symptoms during 24 hours of blood transfusion. Within 24 hours, the most frequent reaction are fever, chills, typically resolve promptly without specific treatment. Other signs occurring temporal relationship in the blood transfusion such as dyspnea may be first indication of potential. The causes of adverse reactions are multifactorial, immunomediated, some of the most feared occurring. So if you see this blood transfusion reaction, fever, chills, pruritus, these respond spontaneously. Dyspnea, pyrexia, these are the serious reactions, causes multifactorial immune-mediated component mismatch, non-immune mediated product contamination. Transfusion-related lung injury. Got a bad unit. G is graft versus host. O is overload of transfusion. 3. T is thrombocytopenic. A is alloimmunization. B is BP unstable. BA acute hemolytic reaction. D is delayed hemolytic reaction. U is urticaria. Neutrophilia. I is infection. T is transfusion injury. Acute hemolytic transfusion reaction due to incompatibility, hemolysis for RBC, shock, line pain, DIC, Coombs test for the hemolysis. Other tests unconjugated globin. Delayed hemolysis may occur in 5 to 10 days after transfusion due to antibodies. Immune-mediated reaction, got a bad unit, transfusion reactions, ABA incomplete diagnosis, normal due to ABA incompletely, coagulation, Coombs test should be confirmed hemolysis. Now here is again the viruses regarding oncoviruses, Epstein-Barr virus, Burkitt lymphoma, hepatitis HP virus, human papillomavirus, cervix, anal, penile, vulval, oropharyngeal, herpes simplex, Kaposi sarcoma, hepatitis B, hepatocellular carcinoma, hepatitis C, hepatocellular carcinoma, human lymphocytes, Hodgkin's lymphoma presents asymptomatic lymphadenopathy, cough, Epstein fever. These are the symptoms. Weight loss, fever, night sweats. Then the stages are single node region. Stage 2 is diaphragm on one side, 2 or more sides, both the sides of diaphragm. Stage 3, stage 4 extranodal sides. Then there are subtypes of the Hodgkin lymphoma: nodular sclerosing, mixed, lymphocyte depleted, lymphocyte rich, NSHL, and lymphocyte rich and depleted. Treatment is multimodal: CT, MRI, excision of biopsy of the lymph node, Epstein-Barr virus. Prognosis is nodular sclerosing is best and lymphocyte depleted is the worst. Now these are some of the revision notes of pathology. Neoplasia we have already seen. Abnormal tissue, angiogenesis, necrosis, germline tumors. These are mnemonic is teratomy, embryonal cancer, germinal tumors, epithelial, glandular, squamous, Nottingham prognostic index. It is indication of survival. Minus is indication of survival is weightage more to prognostic factor than size. Size not given. Tumor size into 0.2. If it is less, it is tumor size less. Lymph node score is important. Grading. This is noting 102. And then prognostic 2 to 1, 93%. Tumor markers we have seen for the ovary, 125, 19, pancreas, breast, tumor antigen, PSA, alpha fetosis, enzymes, alkaline phosphate, hormones, calcitonin, maternal and oncogenes we have seen proto oncogenes, RAS, NYC, AV, classification oncogenes, transcription factor, NYC, reception, tumor suppression genes 53, chromosome 17, BRCA, paraneoplastic, thymoma, small cell, pancreas, trochus, sign, breast, dermal, carcinoma syndrome, secret products of endocrine cells, serotonin, bradykinin, origin neuroendocrine cells, hormonal symptom development, sweat system, flushing, wheezing, papillary, rule of 3, one third, multiple, small bowel, secretome, 5 scintigraphy, carcinoma, lungs, bronchoasthma, Kulchit's cell, appendix less than 2 centimeters, small motion, radio scan, bone secondaries, breast, bronchus, renal, papillary, osteoma, Merrill score. Merrill score, pathological fracture, osteoclasty, score, sight, pain, X-rays, upper limb, lower limb, trochanter, pain, mild, moderate, functional, X-rays, plastic, mixed, lytic, sight, less than 1 quarter, score, risk, 9 or more, impending, prophylactic fixation, less, not impending, non-operative treatment, hyperkalemia, chromosome involvement, chromosome 1, 11, 13, 16, 17, 16, 17, chromosome 1 neuroblastoma, Wilms, 13, retinotheriac, solar polycystic kidney, and neurofibroma and neuroblastoma, 1, 17, organ transplant, skin kyphosis, occupational cancers, mesothelioma, bladder, non-melanoma, skin, lungs, synovial, occupations, construction work, and the industry, suit, chimneys, mesothelioma, dyspnea, weight loss, management, wound healing phases we have seen hemostasis, inflammation, regeneration, remolding. Initially vasospasm, erythrocytes, seconds, neutrophil migrates, febrile regeneration, remolding. Factors didn't heal. Diabetes, infection, drug, neoplasia, tissue necrosis, axis, hypertrophic scars, and keloid confined to wound, keloid beyond the wound. Fat embolism, clinical features, CVS, increased heart rate, respiratory rate, dyspnea, skin, CNS confusion, imaging, CT, no initial groundless appearance, treatment prompt, lymphadenopathy, Hodgkin's disease, HODGI, Hodgkin's disease, hematological, oncological, dermatopathic, Gaucher's disease, Kawasaki's disease, infection, human fix, serum sickness, drug reaction, immunological, SLE, sarcoidosis, endocrinological, anemias of two types, male, female, less than causes decreased production, RBC formation, decreased RBC formation, increased loss. Physiological pregnancy, morphology, microcytic, normal. If you see micro hypochromic anemia, normal, thalassemia, malabsorption,